I would just like to start by telling you maybe a little bit about Triangle, why it exists and what it does. In terms of why we are here, Triangle's vision is to build better lives together, and I think together being a critical word in that, because it's together with service users and it's together really with all of you here today. We can't do it on our own. And in terms of what we actually do, our mission is to deliver quality housing and appropriate support to people in need, promoting equality and opportunity for all. In terms of the specifics, we do 5 specific things. We build houses and we also build communities. So to date we've built approximately 700 units of accommodation, and we plan to start a further 300 units over the next 3 years. And 65% of those units to date are supported living type accommodation. And over the last 3 years we have delivered about a third of the supported living starts of the social housing development programme. And we plan to do the same in the present year. But after that, we're not so sure what's going to happen. And if you can bear that in mind. So years 2 and years 3 of the programme are a big question mark for us in terms of supported living accommodation. In terms of building communities, the inclusion of people with disabilities in the community is absolutely critical. So we undertake a number of programmes to facilitate and encourage that. We also support about 450 people each year in finding accommodation with private landlords or other social landlords, those who have homelessness issues, quite often emergency homelessness issues. Mostly those people find accommodation with private landlords. We also support people with disabilities to live as part of the community within supported living and outreach services. And as Brian has said, our focus is predominantly on people with mental health and learning disability issues. So we support about 180 people in about 23 schemes. And we also have some what we call peripatetic services, ongoing services to people in the community as well. Fourthly, we also help people with disabilities to train and keep a job. We work with about 150 employers to support over 300 people in jobs. And we also operate 5 social firms through, as was outlined earlier on, an organisation called Alternative Angles. These are firms that do trade, but they are in essence training organisations, so they're not profitable organisations, and that's important because we feel it doesn't then restrict the nature of referrals that can come into those organisations. And finally, as we need to work as a responsible employer in our community. We employ some 400 people at present, and obviously we have a responsibility to the wider community around us as being a large employer in the areas that we work. What do some of the schemes look like? The supported living projects? Well, there's nothing unusual about them. This is a recent completion of a new build in the community for, we have 2 2-bed apartments and 10 1-bed apartments for learning disability in Coleraine with some communal facilities. These are some of our schemes just recently completed in Belfast. Nothing unusual about these houses. They're just ordinary houses in the community, small shared houses for people with learning disabilities. And some of our recently completed projects in Ballyclare. All of those projects for hospital resettlement. But bricks and mortar, however, are only one part, if you like, of what we're doing. Say we are building better lives together with you. I just want to tell you a little story. Here's Sean's story, because hopefully it will be an encouragement to us. That's Sean's signature sign-off. So I think hopefully an encouraging story for us all. But Sean's journey hasn't been always that easy, and I think it is important that maybe we focus now just on maybe some of the policy and process issues around commissioning that certainly Triangle as a provider has faced, and as a provider of housing, the bricks and mortar, and as a provider of services, hopefully we can bring that perspective to it. So we're looking at the capital issues that we face, looking at the revenue issues, but also looking at it from the end user perspective, the Seans of the world. the commissioning challenges, Bamford, from famine to feast. I think that many of you who were involved in the introduction of Bamford, and particularly the introduction of the capital money for the bricks and mortar that happened some years ago, many of you who were around at that time will remember the famine that was in place before Bamford came into place. The supported housing programme, sometime in the distant past, I can remember, made up approximately about 20% of the social housing development programme. At a broad guess, I reckon that had gone down to about 2 or 3% just before Bamford was introduced. So we had moved towards a famine, if you like, in terms of the delivery of supported living accommodation. And then, bang, Bamford occurred. And all of this capital money appeared on the scene. And suddenly, that nature of that provision was to increase from the 2 or 3% that was around in the programme right up again, probably to the 15 and 20% of the programme that it makes up now. But it just couldn't happen overnight. And unfortunately, I think that we've been struggling to catch up since that happened. We moved from a famine to a feast. Now, I did mention earlier on that Triangle will continue to deliver hopefully about a third of that programme in the incoming year, but in the next few years, we're not so sure what's going to happen. Why? Because there have been specific targets set for hospital resettlement, and we are significantly worried that once those targets are achieved, what comes next? What comes next? Are we engaged with the community population out there in terms of mental health and learning disability? Do we know what we need, what needs to be provided? We're not so certain, and we're scared that we're going to move from feast to famine again. And I think that is one of the challenges that we face in the next year. In terms also of engagement, I think I must say that from the provider's perspective, engagement at the outset in particular over the last 3 to 4 years has been significantly slower from the social care side. Now that may be for a number of reasons. I think that the social care side, there was a series of reorganisations occurring at the time when Bamford was introduced in terms of the structure of the social care trusts. Also, in terms of revenue money, it was quite clear that in the early stages, when the capital arrived, that the revenue was not in place for the trusts to bring the schemes together. But I also think, and it has been touched on earlier on, that in terms of regionalisation of planning, that has been weaker on the social care side. And I say that for a number of reasons, and I think, again, it's related to the structures that are in place. It's really in recent days that we feel that the Health and Social Care Board has got, if you like, involved, but we've still to see DHSSPS involved. Where is DHSSPS in the planning and moving forward? There doesn't seem to be a regionalisation of planning on the health and social care side when wanting to deliver supported living housing. And I think it is a weakness in the process. And in many ways, I think from a provider's perspective, it's the supporting people team who are the glue in much of what's happening. It feels as if it's the supporting people team that in essence are the protectors of the integrity of the commissioning process at times. And I think that is the experience of many providers. I think that in terms of engagement, it's changing slightly in terms of, we talked about the commissioning process earlier on and the Health and Social Care Board involvement, but local commissioning groups, from the provider's perspective, we're not sure where they are or what's happening. And I think that there's something fundamentally missing, therefore, in that commissioning process. In terms of DSD, NIFA involvement and housing executive, I think there's so much to be positive about and so much that is really helping us to deliver. In terms of clarification of responsibilities, I think there's a number of areas that we need to work on. For example, I can give you examples. We've talked a lot about smart and assistive technology earlier on this morning. But in many cases, schemes are being specifically delayed because there isn't agreement over who will fund the smart technology in new schemes. Should it be there at all? And if so, who's going to fund it? And schemes are being delayed. We have examples of schemes that have been tendered, that are ready to go, but there isn't fundamental agreement on who will fund specific aspects of the smart technology. We're working our way through it, and we think we'll get there, but really should it be delaying schemes? In terms also of special needs management allowance, there's an uncertainty of the future of who will be able to fund the differential if special needs management allowance is removed, and we need to work our way through that. And we've talked a lot this morning also about procurement, but a lot of delay has occurred in terms of deciding to procure or not to procure. And I think especially again from the health perspective, there are five regional bodies, if you like, and there are differences of approach within each of the health trusts. So again, a regionalisation of approach would be critical in that area to avoid delay. In terms of needs assessment, again, issues of, certainly from Triangle's perspective, we've found that when it comes to needs assessment as part of the business case, sometimes we feel it is a virtual needs assessment rather than a real needs assessment around specific individuals. So what has it led to? It's led to aborted schemes. Some schemes that are quite far down the process, they've received planning, there's been community consultation carried out, and so on, but they abort with significant costs to the provider, Triangle, in that case. Also, in terms of voids, a scheme is maybe commissioned as a 4-person unit, but 2 or 3 arrive, or sometimes 1. And there's a delay, sometimes a very long delay, but again, that places significant risk and significant cost on the provider, the housing association as landlord losing the rent, and if it is a separate provider, it's the revenue costs associated with that income, because quite often the expenditure associated with staff cannot be reduced to in a sense, meet the reduction in income. And that is critical because from a housing association perspective, we're quite often borrowing 30 to 40% private finance to build these schemes. And from the support providers' perspective, quite often they're working with staff early on in the process and everything is delayed and they don't have the money to continue to support staff in what they're doing. So there are significant challenges there that are still around. And that brings me essentially then to the issue of risk sharing. It feels from a provider's perspective that the risk is all in one area. If there are voids, who's carrying the risk of the lack of income and the increased expected expenditure? It's the providers who are carrying that risk. And I think, again, that brings me back to regionalisation. I think that we need a regionalised approach to it, and that's, I think, where the Health Board and the DHSS PS need to come in, because I think there is a need for regionalised contracts that deal with issues of voids and deal specifically with risk sharing, because we can't carry on, if you like, with some of the scenarios that exist out there for providers. Also, in terms of the challenges, community consultation. This is one of the significant areas of where we really need change. Some of the pictures that I showed you earlier on, they're just ordinary houses in ordinary communities. But we do, under the guidelines that we're issued with, we have to go to that community and explain what we're doing. We have to go engage with that community, and that's fine in a sense, but what in essence are we doing? Because the house is already there. We're engaging with that community to tell them about the people that are going to live in the house, not about the house that's already there. And to me, that just doesn't stand up to any form of equality, because you or I do not need to go and ask someone's permission to buy a house or live in it. And I think that we really need to look at what we're doing in that area. And it's going to require also, because there's significant opposition, we've had a number of schemes in the last year that have been withdrawn because of community opposition to specific schemes, supported living schemes. And I think that we really need political leadership in that area. We really need to engage with our politicians on this matter, and we need to engage with communities, obviously, as well, so that they will understand there's a community education programme of the real benefits that people with disabilities bring into those communities, and the real vibrancy and colour that will come when people live in the community. 5 minutes, okay. In terms also of sustainability of existing schemes, I'll not say too much on this, but the issues have been raised around, the fact that the budget has been fixed now for some 6 years, and that staff salaries maybe can't increase, but also the quote that came earlier on in regards to the road to the bottom, I think applies in many ways. What's happening is we're driving down wages, we're destabilising services, we're crushing innovation. It's drawing upon limited resources away from the real work with service users. That's the reality of what's happening there. And I know it's happening throughout the public sector, but it's certainly happening in the Supporting People programme. So those are the challenges in the sense from, I think, that are out there in terms of maybe from a provider perspective. But in terms of the end user, I think there are a number of critical things. First of all, I want to spend my money on my house. The hospital resettlement programme has been successful in many ways, but there are so many examples out there of individuals who have been supposedly resettled from hospital but find themselves, for example, trial on leave. This idea that maybe for 3 or 4 months they're trying out their new home. But their monies are being restricted, so they can't buy certain things, they can't live and engage in the community in the way that you or I would normally engage in. And what it's actually doing is threatening the success of that tenancy and of that integration into the community. And I think that we really need to engage in that with the hospital and the trusts to try and resolve that issue. On that point, advocacy is critical, but also in terms of the resettlement programme, resettling somebody with day opportunities is also critical, and sometimes that gets a bit lost. We need to know that individuals have a package of support and care around them and have that integration and that opportunity for day activities as well. And it's not always there in the resettlement planning process. So I've concentrated on a lot of the negatives. Just to close, what about the future? Well, I think that we do need to deal with those commissioning challenges, and there are a lot of negatives in all that. There are also a lot of positives, and I think that we need to also focus on what is good in what we have. Sean's story is a great story, although there have been challenges along the way. But in terms of the good of what we have, I believe, have something unique here. We have a Supporting People programme that's regionalised for a start. We have a Supporting People pot of money that's ring-fenced. I think that is so unique to this regional area that we need to protect it. We all know what's happening in England and Scotland and Wales when that has been removed. So let's focus on the good that we have, and let's really build on it. As I've said, we need to plan beyond resettlement. I've got this awful feeling that we're moving from feast to famine again, because I haven't heard really anyone engage on a regional level about what's happening after the hospital resettlement programme, and it finishes in March 2015. We need to bring the wider community with us. As I've just said earlier on, I think that's absolutely critical. And finally, I think that we also need to support staff to flourish, and I'm really glad to see that later on we are looking specifically at that area, because look, pay is only one part of recognition. But if we happen to be paying support and care staff the minimum wage, what does it communicate? Really, what does it communicate? And I think it is an area that we need to fundamentally look at as well in thinking about the future. Thank you.